Hello, my name is Dr. Aslie. I'm a board-certified fellowship-trained spine surgeon. I'm the medical director here in Sacramento Spine Treatment Center. In this segment, I'll be discussing with you a surgery called posterior lumbar fusion. Posterior means through the back, lumbar means lower back, and fusion means turning the two bones that are moving against each other into one bone, eliminating motion and eliminating pain. The indications for the surgery are continued low back and leg pain for what we call a degenerative disc disease. Now, before we go any further, I need to tell you what I feel about that name. The name degenerative disc disease started when the spine surgery was very young. They would have x-rays, they will look at the x-rays and we'll see that some of the cushions between the bones have deteriorated and the two bones are grinding against each other, and therefore they call it degenerative disc disease. Now, after years of surgery and research, and of course, invention of imaging studies, most importantly MRI, that we can actually see the discs and see the progression of it, we realize that most of these are damaged discs. Some trauma happened. Therefore, the integrity of the disc is very important, to a point that some of the surgeons believe nowadays that even putting a needle into a disc can cause the integrity of that disc to be violated. Now, once that happens, it's like a tire. Disc is like a tire. So if you put a needle into or a nail into a tire, within the next few days, the air goes out and it deflated. So is the disc. If it gets injured and there's a violation of its integrity, within the next few years, it loses its ability to absorb shocks and its tightness, and it settles down and deteriorates, and in some people becomes very painful, causing significant low back and the leg pain. Therefore, I believe that the most appropriate name for this problem should be damaged disc disease. Now, there are some people that are suffering from truly degenerative disc disease. These are the people that they have collagen that is not as strong as the average person. And some of these people, they have relatives that they're suffering from back pain. But that population is small compared to the people that, if you go back, you can find a history of trauma that started all this or started the damage to the disc. Now, if the patient comes to me with the low back and leg pain, my job as a surgeon is to avoid surgery. Therefore, we'll try whatever we can. We'll try what we call a non-operative care. That includes physical therapy, epidural injections, chiropractic care, acupuncture, and if those don't help the patient and the pain is quite severe and the patient cannot stand the pain, then our job as surgeons is to tell them if we can help them or not. The decision for surgery or no surgery is the patient's decision, if the indication is pain. And if the patient decides to proceed with surgery, then we can go ahead with the surgery, if we have a good evidence on the MRIs what's causing the problem. Once that happens, patient comes into the operating room. We give them antibiotics to decrease the chance of infection. Patient goes to sleep and they lie down face down on the operating table. Now, this is a model that, as you can see, has a fusion at the level of L5 and S1. We make an incision appropriately for the size of the fusion over the skin. We take the muscle off the bone, and pretty much this is what we're looking at into the back of the patient. Then we put pedicle screws. Now, these are the pedicle screws. These are actual implants that end up inside the patient. They are a screw with a tulip that fits a rod in it. So you can see that screws have gone into the pedicle, into the vertebral body. This is a glass model that you can see. There are two pedicle screws. This is the back. This is what the surgeon sees. And they go through the pedicle, which is the bony bridge that connects the posterior structures to the anterior vertebral body into the vertebral body, as you can see right here. In this model, the posterior lumbar fusion has been combined with the anterior lumbar fusion, as you can see right here. And I'll cover the anterior lumbar fusion in a different segment. Once we put the screws, we connect them with a rod, and that locks the two vertebrae together. Now, this is instrumentation part of the surgery. Now, of course, the most important part of the surgery is the fusion. Now, what that is that we get the local bone, we mercerize it, and we lay it down between the two bones. Now, within the next 5 to 6 months, that will turn into a solid bone. Therefore, the two bones will turn into one bone, and that is the surgery. And if that doesn't happen, the screws will eventually fail and get loose. Therefore, we have to do the surgery all over again. And that part is part of the patient's biology. And as surgeons, we don't have any control over it. As a matter of fact, patient has the best control over it by following directions and not stressing their surgery. Therefore, following the post-op instructions are very important. Once we do the surgery, we close the wound. Patient stays in the hospital about 2 to 3 days after surgery, depending on how much pain they have. We want the patients to get up and walk the next day after surgery, because if they don't, if they lay in the bed, they are prone to complications like pneumonias, heart attack, and those are not good. Therefore, patient needs to get up and walk around the next day. By the time they go home, which is 2 to 3 days after surgery, they should be decently comfortable enough to get up, go to the kitchen, fix themselves a sandwich, or be able to get up and go outside to get the mail, small walks. By the time they come back to see me 2 weeks after surgery to remove the staples, patients should be able to get around the block maybe one time, small block, and should be decently comfortable. The surgery pain goes down quickly within days and then plateaus for many months. After all, it might take up to a year to recover from surgery in this magnitude. Now, a lot of patients actually they get comfortable by 3 to 4 months after surgery. Why? Because the surgical pain has gone down and they're bolted in. But that's very dangerous, because if they increase their activity, they can jar the area, therefore stopping that fusion to solidify. If that happens, which we'll call a non-union, we have to redo the surgery. Why? Because the pain will come back 6 months after surgery a lot worse than original. And that's why I tell my patients 3 to 4 months after surgery, even though they're comfortable, I tell them that you're not healed yet. You have to be very careful with your back. And that's very important. Now, some of the risks with the surgery, every time you make an incision in the skin can get infected, or you end up with an infection. Chances of that is very low. I get pretty much 1 infection every 2 years, maybe. If that happens, we have to admit the patient to the hospital, wash out the wound, and put them on antibiotics. These screws are placed into the pedicles, which are very millimeters away from the nerves. So nerve damage is one of the complications. Has never happened in my practice. And the nerves are floating in this sac filled with cerebrospinal fluid called dura. If you are doing a laminectomy and discectomy and you're manipulating the dura and you end up with a tear or nick, the cerebrospinal fluid can leak, and therefore you have to repair that leak. That's another complication. But overall, chance of complication is not very high with these type of surgeries. The rehab is very important, as I discussed, and following directions after surgery is very important. I like to give my patients a brace, but the brace is really there to let them know that they had back surgery, but a lot of my patients like it because it gives them support. I hope you enjoyed this segment. In the next segment, I'll be discussing with you the anterior lumbar fusion. Have a nice day.